where you've got a lesion that's involving the internal carotid artery and you do a test balloon occlusion and the patient fails the test balloon occlusion, you may or may not have the expertise to do an external carotid, internal carotid bypass, or you may elect to stent the patient. Can I just ask for the panel's experience with that situation?
Let's go one step down from that question. Let's talk about indications for a balloon occlusion. When do you guys use it? And then we will talk about results of the balloon occlusion test.
So the indications for balloon occlusion test would, in my hands, would be a higher grade lesion that has carotid involvement that approximates 180 degrees of the carotid. And by higher grade lesions, I mean chordomas, sarcomas, cancers, WHO2 and 3 meningiomas would be in that differential. Schwannomas that are abutting the carotid artery in the peripharyngeal space or in Meckel's cave, something I would not consider doing a balloon occlusion test for. Craniopharyngiomas, I routinely don't do balloon test occlusions for. Pituitary adenomas, definitively not. So that would be my general algorithm for thinking about doing a balloon test occlusion. That's not without significant risk. I mean, the balloon test occlusion has got a 0.5% stroke rate in this day and age. So doing a balloon test occlusion is not an insignificant task. So I think that you have to really understand that the carotid is truly at risk, and that the risk of a 0.5% risk of stroke outweighs the potential for a carotid injury, which is reasonably low in most people's hands.
So if I may summarize what you just said, you use a balloon occlusion test on an invasive lesion that you want to remove completely.
That's correct.
Okay. Anybody with any other different paradigm?
I'd just like to add to that, if you can't remove, if it's a malignancy and you can't remove it completely, then I won't balloon occlude test, because I'm going to be leaving tumour behind and I'll leave it around the carotid artery. So we only balloon occlude the carotid artery with a malignant disease if we know we can get it all out.
So in other words, it's a little bit more explanation of the same subject. Is you have to have a lesion that you're contemplating removing it completely, at least a gross total resection, and that is a high probability of having a carotid invasion. So once you have the balloon occlusion test, let's say that the patient doesn't pass the balloon occlusion test, meaning that they are either symptomatic or they have enough drop on their brain blood flow that you know that they're likely to develop a problem. What do you do?
Well, it depends on where the lesion is, in my opinion. If the lesion's in the sort of the peripharyngeal or extracranial carotid area, in the infratemporal fossa or peripharyngeal space, I have my neurosurgeon, who's a vascular surgeon, assist me. We resect the tumor. If we resect the carotid, if we get in the carotid, we have the arm prepped out for a radial artery bypass, and we do a direct bypass at the time of the operation. When we're doing the direct bypass, there are bypass catheters that you can actually thread above and below your anastomosis to maintain blood perfusion at the time of that operation. If the carotid is involved in the skull base, in lacerum and cavernous or something along those areas, then number one, you have to question the utility of being there. But number two, at that point, it's very difficult to do a direct bypass in that area because of the nervous structures. In fact, it's almost impossible. And so you would do an internal carotid bypass. So you would take the external carotid systems or the superficial temporal systems, come down, find the tent, trace the tent down, and find a distal branch of the MCA and do an internal carotid bypass. We typically, if we're thinking about that, we've only done that once out of 500 cases. If we're thinking down that road, we would do that as a staged procedure.
You do it as a stage procedure? So you do it in a separate analysis?
We do the pterional craniotomy and the external MCA bypass first. And we give that about 2 or 3 weeks to heal, and then we come back with our usually more anterior approach and do the resection.
Rick, just a comment. I think that we have to go back to a very simple concept, that when you have a carotid an involvement of the carotid artery, and you take the carotid artery for any reason, I don't think you are really helping that patient. Even if you do a bypass or you do any big procedure trying to save the patient, I don't think the overall survival is going to change if you do it or if you don't do it.
I have a quick comment on this. If you're going to do a balloon occlusion test, in the pre-op with your CTA or the MRI, you should be able to identify where the lumen size is. The only time we have done balloon occlusion test out of about 720 cases was the time when we had a carotid artery injury during a suprasellar tumor resection. We had to go back and make sure that the other system was viable. I totally agree. If the occlusion of the carotid is present preoperatively, these patients are not best served by any resection. The palliative resection may be a role, but taking the carotid artery and giving them a stroke post-op, I don't think it's a good quality of life in my book.
What about the use of stents? Anybody has experience using stents or luminal protection devices,
No.
pipelines?
No, I don't. I can't convince my radiologist to put a stent in because they're worried about the long-term complications of it. But Mario Sana presented his series in Paris recently, and I think he's now up to about 50, and he's actually put it in publication because I've been asked to review it yesterday. And he claims that there haven't been any long-term occlusion, strokes or whatever. So, I think some people have had some good experience, but the other people I speak to have not had good experience.
Dr. Ian Woodard, you have a comment, Ian?
No, it's actually two questions I wanted to ask the panelists. Does your method of reconstruction differ depending on whether they've had preoperative radiation, chemoradiation, or if you know they're going to have postoperative radiation therapy? That's question one. Question two is, what's your algorithm for the patient with high intracranial pressure who you repair an encephalocele CSF leak and you're not sure whether the intracranial pressure is still high? Do you still keep measuring them? Do you do repeated LPs? Do you consider the shunt? What's your management?
So let's go through the first question first.
If there's a patient who has been radiated previously, we would definitely consider using a vascularized flap. And as Adam showed, you prefer to put a pericranial flap for cranionasal suppression.
The first question is the radiated field, or if you're contemplating radiation postoperatively, especially proton beam for patients with chordoma, nasoseptal flap is a boon. Definitely a big, big advance in our treatment modality. We use a nasoseptal flap. We want to bring vascular structure to the area which will help the wound to heal faster, better in radiated patients. And if you're anticipating radiation, we definitely want the volume to protect that area well with a repair with a nasoseptal flap.
What about if the patient hasn't received radiation and is going to receive radiation after the surgery?
Yes,
Does it matter?
No, I put in a flap, definitely.
Flap.
Definitely.
Dr.
And
Sanesh?
what sort of a flap?
He's talking about a
Nasoseptal flap.
So
That would be my first choice.
So two caveats. The first caveat is that if the nasoseptal pedicles and the septum were in the gross total target volume of the preoperative chemoradiation therapy, I usually will not use a nasoseptal flap. I think that the cap, now granted, I'm probably hyper aggressive with that problem, but I'll bring in another vascular tissue source, whether it be a free flap or a pericranial flap or a temporoparietal flap. That's number one. That's just my preference. Number two, we looked at our long-term contrast uptake with nasoseptal flaps at the time of the operation, 1 week after the operation, and then after chemoradiation therapy, post-operative adjuvantly with MRI contrast uptake studies. And we showed that the nasoseptal flap is absolutely a robust vascular source that maintains its vascular supply even during chemoradiation therapy. But that's when you put it up when it hasn't been radiated. So.
I think I agree. I think the key is to put a vascularized flap. It doesn't matter which one is it, but if you have the nasoseptal flap there, I think is the first option. And then you go through all the other perical flaps, pericranial, temporalis. that are there. And, or you have a free flap as a last option, which
Rick, I think it also depends on your time since your radiation. So if you've got a planned stage resection after radiation or chemoradiation, I think a local vascularized flap's fine. But if you've got a recurrence after chemoradiation and after 3 years or 4 years, then you would definitely want to put in a free flap in that area.
Pablo, do you have a comment on that regard?
Yes, Castelnuovo, Varese, Italy. So I think this difference if we are speaking about posterior fossa and anterior cranial fossa. Because for posterior cranial fossa, I totally agree. A pedicle flap is the best one. But for anterior cranial fossa, in our experience, we use the free graft, the multi-layer. And in our experience, so many cases, there is no any difference between concerning radiation. And we have no any problem about it. So any statistical difference. So I think it's not only, the concept is not only for radiation affecting the non-vascular graft, but it's a meaning of location. Anterior cranial fossa is different than posterior cranial fossa.
So you see that there's a variety of, or a difference in the way that we repair. Personally, I like to use the vascularized reconstruction, but as Dr. Castelnuovo pointed out, there are other big series like Roy Casiano that also doesn't use the vascularized flap in the anterior cranial fossa, and they seem to get away with even postoperative radiation. They don't seem to have that much of a problem. If you excuse me, we still have one question on the floor, and then we'll come to your question. The other question was regarding high ventricular pressure. So if we go very quickly, this time let's start by Dr. Panizza. What do you do when you have a patient that you suspect that has high ventricular pressure, or you have one that has it for sure?
Yeah, so if they've got high ventricular pressure, I like a nasoseptal flap with a lot of packing. I don't like lumbar drains, but if there's any leak in the early post-operative period, I'll review it, and then they'll get a shunt.
Amir?
So first of all, I repair with a vascularized flap, and post-operatively, I will, about 4 to 6 weeks after surgery, I will do a lumbar puncture to check the intracranial pressure. And if I really make the diagnosis of elevated intracranial pressure after my good repair, I think that patient has an indication for a shunt.
Adam?
I shunt very few patients. I repair them. I put them on Diamox if they have an empty cella and they're heavy set. I've sent them to bariatric surgeons for bariatric surgery and lap band for weight loss, also if they're morbidly obese. I personally think that shunts don't work forever. They have a revision rate that's not insignificant. And so I have a conversation with my patient, and routinely we decide that we're going to try these conservative things. If they pop another leak, then I'll just repair it again, and then we'll readdress the situation.
Vijay?
Just a quick comment on this. When you have a high intracranial pressure, it's inversely proportional to the body mass index. If the body mass index is high, most certainly these patients are going to have a leak somewhere, someplace. So when we do these repairs, we usually measure the CSF pressure. If it is twofold, we leave a lumbar drain at least for 48 to 72 hours for the surgical site to settle down. And then we clamp the drain and then wait for 24 hours and then pull the drain. And patients who are obese, who have a high BMI, more than 40, we counsel them first to lose some weight. And like what Adam said, we try to give them a consultation with the bariatric surgeon. If that fails and they're still high, we definitely shunt them. We shunt a decent number of patients who have high body mass index, and we're not shy about that. Using Diamox initially was like giving aspirin for patients with a meningioma. It doesn't really work. And my neurosurgeon didn't believe in that for quite a while. But now we're using Diamox. It's a mixed bag. I don't think we have a good result with the Diamox. So I think it's a question of when you want to shunt the patient, when you don't want to shunt the patient, how long you want to keep the drain, and how long you want to clamp the drain. And this is exactly how we have published a good series of 70 patients with meningiomas with high ICP. And in these patients, we put in a drain, pull the drain out 48 to 72 hours after clamping, and they've done well.
So I think we should differentiate patients with the spontaneous CSF leaks from those patients that develop
Correct.
intraventricular pressure due to a tumor. I think that their behavior is a little bit different
Correct.
from each other. Dr. Pai?
Yeah, I agree with the panelists. Nothing different.
Yeah, Adam, do you have one more
Just one more
comment?
comment. If you have a patient that you suspect has high intracranial pressure, you should also send them to your ophthalmologist to have their retinas looked at, because they can get blunting of their retinal veins, and that can be significant. So that's actually an indication to treat more aggressively up front as opposed to just primary repair.
So I hope that you are utterly confused now, Ian? At a higher level than what you were before, hopefully? Let's go to his questions, and then maybe we can come back to address some of the other issues.
My question is, how on table will you make sure that your cut margins are negative in a cancer case? Or in other words, if the pathologist reports gross disease in the margins, what is the next step you will do? Or, I'll put the question in a little more different way, that what is the difference between the cut margin positivity in endoscopic sinus type of tumor surgery and open type of surgery?
Dr. Pai?
To address that question, we need to understand what is the proximity of the lesion to the vicinity, the orbits, the dura, as well as the bone. So when we are planning to do an endonasal resection, we know that we don't have a gross involvement of the orbit or the brain. And when we are going to resect this, we are going to take the adjacent region as your margin. So for instance, if you have a tumor reaching the lamina papracia, you are going to take the entire lamina papracia coming onto the periorbita for your margin. And that's the best you are ever going to get, even with open surgery. So if you have a positive margin at that point, you're going to consider having to resect the periorbita. If you have a lesion involving the dura and it goes lateral to the orbit, the dural margin comes positive, you are going to convert it using a craniotomy to get a margin on the dura superiorly. So that's the point that during surgery you're going to make the decision to do an open conversion. Right. But that's the decision making pre-treatment. Before you plan this endonasal approach, you are going to be sure that you're going to get a margin on the bone there.
You will have the same problem whether it's an open or an endoscopic approach if you're talking about bony margins, but usually we recognize that type of problem in the preoperative imaging. Vijay, do you have?
Bony margins, and especially skull-base resection tumors, is a tricky game. There's no cut and dry principles in trying to do this. It's not like open surgery in head and neck where you can get a frozen section and get margins. When we have esthesioneuroblastoma, especially in patients who have, after IP cases convert into squamous cell carcinoma, these are two kinds of patients who are difficult to deal with. So we always resect the tumor and then get the edges of the resection for the frozen section, for the margins. And if the margins are positive, we go back further. And of course, as Dr. Pai pointed out, if it is going far lateral, you need to convert. At this point, you have to swallow your pride and do the right thing for the patient and do the open approach if necessary. You have to choose your patients carefully. When you're on the verge of choosing a patient who's got a risky margin, you must be prepared to convert. And almost about 50% of the times, we end up converting. So you have to choose your patients carefully.
Or in other words, I'll ask you, can the tumor biology decide which type of approach you do in open or?
No, not at all. The location, the size, the extent of the tumor dictates the resection.
Emiro, do you have any other comment?
No, really. I think that it's very clear that you have to choose your patient really well, do a very good preoperative evaluation with your CT and MRI to know what are you getting into. So I think that's the most important. So, and I chase margins, until my limit of until my approach, give me that chance to chase the margins.
Ben?
Yeah, no different.
So I will put a little asterisk to Vijay's comment. I think that he's right. For the most part, we use the extent of the lesion and the relationship to critical structures to keep what approach, but sometimes histology may have an impact. For example, in a sarcoma, we would want wider margins than otherwise. So the question that you should ask at that point is, what are you willing to sacrifice? So if you're willing to sacrifice an eye, or you're willing to sacrifice one carotid, then maybe, if you think that will make an impact on the survival of the patient, maybe then it has an impact also on the choice of the approach. But if you're not willing to sacrifice that critical structure, then you have what I call philosophical margins, which is you dictate the margins on what you're willing to sacrifice, not really where the tumor is. So it's a little bit of a nuance that doesn't apply very often, but it does apply when it applies, it's important for the patients.
Can I ask a last?
Yes, please.
After neoadjuvant treatment, then will your technique change? Neoadjuvant treatment,
So-
chemoradiation or something.
Do you want to tackle that
so
one,
I
Amir?
think that with neoadjuvant treatment, you have to choose your patients, and it depends on histology. So I think this is very important. If I have a SNOC, most likely I'm going to do induction chemotherapy on that patient, and they really do respond really well. That doesn't mean I'm not going to do surgery. Most likely I'm going to do surgery afterwards. There's a lot of papers now on induction chemotherapy for squamous cell carcinoma of the sinuses. And those papers come from MD Anderson, showing that you might not need to do surgery. I'm a little bit skeptical with that. So you say if you have a complete response, so you don't need to do surgery in a squamous cell carcinoma if you have complete response. But that's something that is a lot of debate. So I think depending on the histology, I think that induction chemotherapy does have a role. And I will say that the main one is not.
So let me make that a little bit more clear. Do you do your approach on what the tumor was originally,
I
or
do.
what you have left after the induction?
I do. I follow my original MRI and CT scan.
Yeah, but
So
sometimes
that's what the initial extent is what dictates the approach.
Absolutely. And
Ben?
the reason why is because, just give you an example, stationary blastoma, when you treat stationary blastoma with concurrent chemoradiation therapy followed by craniofacial approach, you find about a third of those patients with tumor in the skull base.
Ben?
Well, I was going to say, a lot of the time we use our chemoradiation up front for the SNOOCs and the aesthesios is because they're so large and the damage is going to be so severe. And so when we do go in for those residuals, we don't go and get the original margins because that's the reason we didn't do it to start with. So my question to the panel would be that if you did have upfront chemoradiation therapy and on your post-op surveillance MR at the 3 or 6 month mark you couldn't see any residual, what would you do?
Before we go into that, Dr. Pai?
Yeah, I just need to clarify. We are going to give chemotherapy, as Emilio said, for lesions which are coming onto the orbits, coming onto the optic nerves. You are not going to be able to resect this via an open approach either. So you're going to give chemotherapy with the hope that if it reduces in volume, you're going to get as much margins as possible. So if you consider a lesion which was coming on both the orbits, you're not going to offer this patient bilateral orbit resections. So with the chemotherapy, if you're going to have a reduction in volume, you're going to get your margins on both the periorbitas bilaterally, and that's the best you can achieve. So your objective giving chemotherapy has to be very clear. And once you have given chemotherapy, you are going to stick to the margins that you would achieve maximally. So you're going to remove whatever margins you would get with preserving normal structures on both the sides.
So going to Ben's question as the last question of the panel, if you give induction chemo and all of a sudden you don't have any lesion,
Well, not
what do you
induction
do?
chemo, because I don't think induction chemo gets rid of it. I'm talking about upfront chemoradiation therapy.
Upfront chemoradiation. So does anybody use upfront chemoradiation as induction?
No, we're talking about that situation where you've got to take both eyes out. That's the situation we're talking about. So you're not going to do that. So therefore you give them chemoradiation. And sometimes they do respond extremely well. And if you respond that well that you cannot see any disease left behind, are you going to go and offer a surgery, or are you going to continue observing them?
So I'll give you a good and interesting example. We saw a 6-year-old kid with a rhabdomyosarcoma. And rhabdomyosarcoma was treated with chemo. And the patient had a complete meltdown of the tumor. We couldn't find anything, so we were all very happy. We thought we cured the patient. 3 months later, same size tumor came back. And at this time, we thought maybe we should try to resect as much as possible, debulk, and resect the limits of resection, including preservation of the eye, and try to give chemo again and probably radiate the patient. The patient did very poorly. So the last word in chemotherapy preoperatively, or induction preoperatively, and resection postoperatively with an endoscopic procedure has to be a multi-center trial, and I don't think the last word is in yet.
So I think that, as we mentioned before, the extent of the surgery and whether the choice of the surgery has a great, is impacted by the geographical extent of tumors and the relationship of the tumor to different critical structures. However, the paradigm of treatment, not necessarily surgery, is very much influenced by histology of the tumors. And we're seeing an evolution, as you have kind of read in between the lines of the panel, of the responses of the panel, that many of the tumors that we treated in the past, like SNOC in the past with surgery, now is a tendency to treat them by non-surgical means of chemoradiation. One last comment, Dr. Nicolai?
Yeah, Piero Nicolai from Brescia, Italy. I fully agree with VJ that we have to be very sensitive to the issue of stratifying patients by histology, because it's a nonsense to mix up rhabdomyosarcoma with SNAC, with adenocarcinoma and squamous cell carcinoma. And I think that the experience that we are running now in Italy to have a prospective studies which is addressing 2 groups of patients, unresectable tumor, high-grade unresectable tumor, and high-grade resectable tumor, where we are starting in the second group with induction chemotherapy, is starting to give excellent input, because indeed high-grade tumor are responding to induction chemotherapy very well, and then we can discuss if going to radiotherapy or to surgery. But once again, following the concept that if the tumor was extensively involving the brain or the orbit, after having a good response to chemotherapy and we decide to go to surgery, you have to be very limited in surgery, and we have not to think to sacrifice the eye, because differently we lose the advantage of giving the patient induction chemotherapy. Thank you.
Thank you very much, and with that we conclude the panel. Thank you.